can do it later. Because these are breakthroughs that are just beyond our grasp. So we need each and every one of you. I challenge all of you to think anew about the scourge of cancer. Go beyond your comfort zone. Set and achieve goals that are going to change the way we do this. Think about it tomorrow. Look, I'll conclude by saying that I know I'm sometimes accused with total justification of being too passionate about the things I care a lot about. But when we were doing the Recovery Act, and I was in charge of making sure that my money got spent wisely, and I met with the cabinet 16 times. I met on the telephone for at least an hour with every single solitary governor but one, most every mayor in the country, and most every county executive. I mean, enlarged from as few as 1 to as many as 80 at a time. And there was one program we had, I won't mention it, but we weren't able to get out X percentage of money, about it was $28 billion, that would have an incredible positive impact on energy and on the consumption of energy. So I turned to the head of one of the departments, brilliant guy, and I said, why hadn't this been approved yet? And this person said, I have a 30-person department that has to go through it. I said, okay. And I turned to the other department that was involved, and I said, why hadn't this been done? He said, I have a 28-person department. I looked at my watch, and I said, well, it is now 11 after 10. And at the time, it was a Tuesday. If you guys don't have this settled by 11 after 10 on Thursday, I promise you I'm stripping those departments. Son of a gun. It was done, and well. It was well. Guys, some things you cannot rush. They take time. But some things, the only reason they're not happening, it's not we don't know how to do it. We're not urgently focusing on what has to be done. Finding a director, I promise you, if we lost a director, God forbid, of the CIA, I promise we'd have one very shortly. We lost a general on the battlefield, I promise you we'd have one very shortly. So my plea with you is, and I know most of you are working, not a joke, I know most of you are working 17, 18 hours a day. Help me today be able to go back to the president and tell me what I should be doing, what we should be doing to increase the collaboration, expand the base of knowledge, and have a greater sense of urgency on the mechanical things, on the structural changes that make a difference. You're extremely gracious to put up with me. We need you badly, and I really do believe it's within your power to fundamentally change and turn despair into hope. Not cure everything, but turn despair into hope a lot sooner than later. Thank you for the bad news here. I'm here the whole day. I'm participating in your roundtables. I wish you luck, and help educate me. I mean this sincerely. Help educate me is the best way to go about doing what we need to do. Thank you so very much.
So I think that kind of sets the stage for what we're trying to accomplish here in this meeting. I've been asked to moderate the first session, which is really to talk about the impact of cancer societies and foundations towards the success of the National Cancer Moonshot. And so I'd like to invite the panelists up. We have Dana Callow, board member from Leukemia and Lymphoma Society, Megan Gutierrez, CEO of the Lymphoma Research Foundation, Neil Manier, PhD, VP of Health Sciences, the American Cancer Society. Randy Schwartz, Senior VP of the American Cancer Society, and Lorraine and Jean Sacco, co-founders of the Read R. Sacco Adolescent and Young Cancer Alliance. Please welcome our panelists. So I don't know, we have to be in any particular order. Dana, Megan, Neil, Randy, Lorraine, and Jean. Great. So my background is I am a pure thoroughbred community oncologist. I did my training at Mount Sinai and then at Yale University, and I've spent my entire life in community oncology, but a very high-level functioning community practice that has evolved into a medical home and now is, I think I'm free to say, one of the 169 oncology care model practices, the new CMS project. But we know that we can't do this alone, and that there are so many aspects of patient education, patient financial support, and activism that our foundations, local, regional, and national, help for our patients, support them in ways that frequently outstrip what even the physicians and nurses can provide. So I would like each one of our panelists to just initially share with the group why you think, or why your society thinks, that this Moonshot endeavor is important, and how your foundation, some ideas that your foundation might have for realizing or solving some of the issues that the Vice President has brought forth in his speech. I'm going to start with Dana.
Okay. Hello. How many of you know about the Leukemia Society, Leukemia and Lymphoma Society? Well, that's about 80%. That's actually pretty good. I'm always surprised that I go places that it's not well known, because Leukemia Society was originally a grassroots organization with 50 or 60 board members, 60-something plus chapters, and very locally connected. And over the last 5 years that I've been on the board, we're now at about 25, 26 board members and consolidated, but incredibly more sophisticated, and our goals and objectives have expanded. We have funded about $1 billion of research grants since our founding. This last year we had 70 million went out on research grants. And what I have enjoyed so much being on this board, we just had a meeting, a couple of day meeting in Chicago, is that we bring some of the best together to meetings to talk. Whether it's Drucker or June or Ken Anderson or any of the blood cancer pros come together and they talk and they truly share, and their motivation is there. So I believe that we will continue to fund research and help the researchers do their projects and then share that information one-on-one. We have also, and I think yesterday, filed an IND that we will be holding for an AML trial. You may all know that, which is very exciting. And we will expand our goal if we have the resources. But it's very competitive out there. Cancer research competes with Facebook. That may sound a bit odd, but capital flows to where it gets good resources in return. And so at the end of the day, all of our societies need to find capital to expand our programs, such as I've just described. So I think the Cancer Moonshot is a stimulant. I don't know, not being a molecular biologist or other, I don't know whether the government is a checkpoint inhibitor here or not, or what, but I believe that if we can have free markets work as well as legislation, I think we'll have a much better chance of success.
Great. Megan?
I think the Moonshot has brought needed attention and a very focused concentration to our collective efforts to eradicate cancer. I think already the Lymphoma Research Foundation, which has a dual-focused mission to both fund research and serve those who have been touched by this disease, has already felt that quite acutely in terms of interest in terms of our work, that of our grantees, and of our foundation in general. We've also had the opportunity to learn more about our colleagues in this space, to find new opportunities for collaboration, as well as opportunities in existing duplications. What's probably been most interesting to me is to identify areas of research and programmatic services for patients that in fact are duplicated across the oncology spectrum. And I think one of the things the Moonshot has allowed us to do is learn more about our colleagues' work in this area. And rather than a duplication, doing the same thing on parallel tracks, it allows us to think about much needed collaboration so that we can really find needed synergies to really advance our work and our shared goals. It always, it's brought to mind as I was thinking about today's meeting, a proverb that says, if you want to go somewhere fast, go alone. But if you want to go far, you have to go together. And I think for me, that really summarizes not only the goals of the Moonshot, but of today's meeting. And so very much looking forward to the discussion, to future collaborations with my fellow panelists. And just want to thank you for including the Lymphoma Research Foundation in today's meeting.
Thank you. Neil.
I think the Moonshot is an extraordinary opportunity. It's an opportunity where we truly have a focus on a collaborative approach to fighting cancer in much the same way that I have a picture of a cancer cell in my office. And it always reminds me that what makes cancer so difficult is that cancer cells work together. And in the same way, we have to work together to fight this disease. And we have to work together across the entire spectrum of cancer. And I think that's one of the other really wonderful things about the Moonshot is that it does have this multifocal approach, that we are looking at prevention and early detection. We're looking at research. We're looking at what patients need to break down the barriers that make it difficult for them to access care. We're thinking about health disparities. We're thinking about the needs of underserved patients. And from the perspective of the American Cancer Society, collaboration across all of those areas is really instrumental. It's instrumental to not just making progress, but being able to sustain the successes that we achieve and that we see through this effort. We're really fortunate in that we have opportunities for prevention and early detection for those cancers where we have the ability to screen, making sure that we make screening available to everyone who needs it. How do we make sure that we reach the highest possible rate for screening for colorectal cancer? So all of those things will help us in terms of preventing cancer, in terms of detecting it early so that people are able to survive their cancer diagnosis. And for the American Cancer Society, the opportunity to partner with our academic partners around research, around patient services and programs, partnering with other foundations and other societies is a part of our DNA in terms of how we do things, but I think it's also what we all need to do. One of the things that really struck me about the Moonshot is today. It's all of the different convenings that are taking place around the country, the convening that's taking place here, and the fact that this Moonshot hopefully will really create an environment where this becomes a part of the DNA of how we all operate in terms of our approach to fighting cancer.
Thank you. Randy.
Thank you. Well, first off, everything the Vice President said was like ditto, yeah, and yeah, what he said. So a few things. First off, the American Cancer Society is the largest private funder of cancer research outside of NIH, and our niche, if you will, is young investigators who have not previously had NIH R01s. They're early in their career, and the funding from an organization like ours helps them get a kickstart for that and hopefully expand their research portfolio over time. That's been critical. So that's really important, and we are looking to double our research budget over the next several years, and that means double the amount that can go out to the researchers. So that's really critical. I think we have, the Vice President said this as well, if we apply what we know, 2/3 of cancers can be prevented. So, I mean, we know it. tobacco, obesity, screening. Right there, you can take care of a lot. We know tobacco is fraught with politics. Much of cancer is political oncology as opposed to clinical oncology. And we know that every state house and on Capitol Hill, there's all sorts of politics around tobacco and now again around obesity and the contributors to obesity as well. So that's an important part of what we can do to prevent. Screening, again, applying what we know. Neil mentioned colorectal cancer, and I think earlier Dr. Evans did as well. If we apply what we know around colorectal cancer, our ACS epidemiologists have done some work, and we're part of the National Colorectal Cancer Roundtable, which has proclaimed a goal of 80% by 2018, 80% screening rate by 2018 nationwide. I think, and help me if I can't remember this, over 300,000 cancers prevented by 2030 if we were to achieve 80% by 2018. So the impact is great. The issue of disparities, Neil brought up, the issue right now in our country of the huge disparity in mortality from breast cancer between black women and white women is something that is just wrong in this country, and we need to do something about that. So again, if we apply what we know, it's critical. Health coverage is critical. No matter what anyone believes politically, you could put any spin on Obamacare, whatever it is, health coverage is a science-based fact for cancer outcomes. So we know that people who have coverage, and our own ACS researchers did research and studied this right around the whole time of the debate around the Affordable Care Act. People who have coverage have better outcomes. And it's obvious to the people in the room, but we need to get past the rhetoric and look at this as ACS did through the lens of the cancer patient. When you look at it through the lens of the cancer patient, coverage is critical. We need to bridge the gap between healthcare and public health, and even with the Affordable Care Act, still have funding go to the CDC, to the state public health agencies for outreach and other programs on breast and cervical cancer, colorectal cancer, tobacco, and other programs. So because we have the coverage here from ACA, it's not reaching everybody. We can't cut the programs that will help promote the public health approaches to this. And we need also, and the Vice President said this, we've talked about this here already today, access to clinical trials is critical. And not everybody is in Boston, and I live in Maine, in a rural area. For people to get from rural America to the clinical research centers is critical. So we need access, both literal, logistical, transportation, getting people access, but linking up with the community oncology programs and developing networks that will help do this, and again, with partnerships and collaborations. Before I was at the National ACS office, I was here in the New England Division, and last week, New England Division hosted the Cancer Center Leadership Roundtable. People from, and Dr. Evans was there, people from all over New England taking off their competitive hats and coming together and talking about how we are doing this and how we're going to do this. And a couple of years ago, the topic of discussion was clinical trials, how we collaborate and do that. So, we have research collaborations. New England is a very collaborative environment generally, and I'm sure it's competitive in certain pockets and certainly in medicine, in academic medicine and in certain areas. But we have a great track record in New England of collaboration, and all the things that we're talking about here can be helped by collaboration.
Thank you. And do you both have something? Or you have a tag team? Okay, let's because save the best for last.
Well, first of all,
That was enough.
first of all, I truly feel that we've already made such a major step here today, just coming together. This is a huge step, not just here in New England or by the nation. So I am more than excited, enthralled to be a part of this moonshot, this first step to, I finally feel like that we could see that day for these cancers to be eradicated. We're part of the Read-Our-Sacco AYA Cancer Alliance, and we're not we're not focused on just one type of cancer, but we came about to focus on an age group of cancer patients, and those are our adolescents and young adults, which I'm sure a lot of you here probably know that those are patients with cancer ages 15 to 39. And in this age group, there has, when we talk about clinical trials and care, treatment of almost any sort, it hasn't been there. So, in fact, our vision and mission statement, it's funny when we talk about it was a dream of ours to see that someday these cancers will be eradicated. And here we are today that when we first was driving in, I was saying, and you know, our fear was that we would not see that day, that our dream and our mission statement was to, you know, to have cancers to be routinely curable. And it was a worry, but coming here today, everything we were talking about, I'm feeling so positive that that dream will come true in our lifetime, maybe. And hopefully for all those AYAs diagnosed with cancer, our adolescents and young adults, I hope that in their lifetime that we see that day, that these cancers are preventable and routinely curable. And by what I heard today from Vice President Biden, I am been positive all the way for these many years of now 12 or more. But today, I am assured that together we're going to do this. This is wonderful. Thank you.
Yeah, we've been at this now for about 12 years, and it really started about 14 years ago when we tried to save our son's life from cancer. We were unsuccessful. And in those 14 years, I have to be honest, I've heard about I've seen incremental progress in the treatment of cancer in some of the cancers that are striking adolescents and young adults these days, okay? But I haven't seen those breakthrough therapies that we were hoping for in this time. They just doesn't seem to have been happening. And also, from time to time, we hear about new promising leads. But why do those leads why are there so few of them? It seems like there should be more. And why do those leads seem to take so long to get developed and reach the patient? So you can imagine how delighted we were to hear about Cancer Moonshot, because it seems to me that this is exactly what we need right now to help accelerate the pace of discovery and development of those new, innovative, breakthrough therapies that we're missing right now. And it's exactly what we need to transform the very processes for discovering and developing those therapies. So we're just absolutely delighted to be a part of this and to see all of that happen. So in our mind, this is really the essence of what this project is all about, to really accelerate the pace of that discovery and breakthroughs.
Thank you. I have so many things here that this group has potentially been charged with to talk, and I know that we want to open it up for everyone to have a chance to speak. I think I'm going to make a decision here, and in the time we have left, which I think is about 15 minutes, to take on the subject of putting the patient in the center of access and care. And what this means is that we put aside our institutional significance, our personal significance, and our personal agendas to really make it happen for the patient. And since I have experts here in societies and foundations and support of the patient, let's take on that subject. So what unique attributes could we bring out of this meeting that really would alter how we as foundations, academic support, patient assistance support, coming out of grassroots efforts like Sharon Snell's foundation that serves my office in Brunswick, Maine, to large national organizations. How do we really get the support to the unique individual to allow it to happen? And I think Dr. Evans would like it open to the floor as well. So anyone wanting to take a crack at that, we're looking for out-of-the-box, innovative ideas here.
Well, I'll start by making an
Great.
observation. Dr. Evans started out with a triangle. I've forgotten all the pieces of the triangle, but you had the patient in the middle. And I actually come to the table with two other hats. One is the hat of a founder of a company called Parexel, P-A-R-X-E-L, which is now a almost 20,000 person clinical trial organization. We've done thousands of trials. And their clients are pharma. And our triangle that we work in my private equity business, which is investing in healthcare companies, primarily now focused on cancer, is a triangle of the payer, the provider, pharma manufacturer, with the patient in the middle. And I would say, primarily because of what the initiative of the Affordable Care Act, at no time has that triangle, if you do that triangle, by the way, in triangles, the patient's triangles gets in the middle and gets smaller and smaller and smaller. And with 70% of Americans now covered by one of 4 insurance companies, think about that, with pricing out there being effectively established with CMS in a negotiated situation, the payer is in huge, the patient is in huge needs of support.
Yes.
And the economic viability of what is a precision medicine model has to be tested. Henry Ford came out with the Model T in one color for everybody. When you stratify patients and you have science going ahead of the economic model, which is appearing where we are today, it's incredibly exciting. But at the same time, we have to solve the other side of it so that the pump can keep primed and fueled and keep going. So I think our societies are becoming more and more important as we go forward. We need to have enough resources to have an impact, whether it's on Capitol Hill here or down in Washington. So I think we have to understand that we're living with MDs and PhDs in the room, but there are MBAs and administrators on the other side somewhere that we're going to have to work with collaboratively with them as well.
Right. I mean, we all have patients that, they have great insurance until they realize their insurance isn't great and that they have a $3,000 or a $5,000 or a $10,000 deductible, and that is their barrier to starting their cancer treatment. And so I agree, solutions need to be worked out there. Also, the idea of testing this precision medicine model is something that I actually mentioned to Dr. Soonshung. Is the oncology care model an opportunity to test that and really determine, can you do a better job, and can, even though the test might be a little on the expensive side, in the long run, are you able to serve the patient better, have a better outcome, and perhaps be more thoughtful in treatments that you select if you do implement these genomics appropriately and earlier?
Tracy, could I just add something about, I think all societies and foundations and alliances, they were at one time and still are very firmly rooted in the community. And so being very strongly connected to the community, you're a lot closer to the patient. Yes, they have to go to the hospital at some point, but they don't know what they don't know unless you've got societies like this at the grassroots in the community level. So staying there, we make them more aware of what the problems are, what might be a problem, and where to go a lot faster that way.
And that's a great point. And I'm wondering if in New England, if there could be like an ad board for the various foundations, be they a grassroots group like the Snell Foundation right up to our national organizations, so that, you know, if one person can't fulfill the need for the patient, there's an easy way to get the patient where they need. And also linking in the academic centers and right into the community practices, the financial advocates who are pretty facile in finding support, but would probably benefit from that type of experience. Yes?
So,
You want to go ahead?
just to mention on the last point, I had something else, but the ACS's call center, 24/7, 365 days a year, is not just about ACS services, it's about everything in the community. So it's a really valuable resource, and also through our website. So we look to do sort of a community resource database for anything that patients may need, and that's a really valuable resource. I was going to say clearing out barriers, implementing policies that help, such things as better implementation of palliative care processes for patients, and working with hospital and healthcare systems to make that a stronger part of the overall continuum of care. It's and at this meeting last week that we had on the Cancer Leadership Roundtable, again, the sort of connotation amongst people that palliative care is only end of life or hospice, when it's not. So that looking at the treatment modalities and ways to implement that and build that out, you know, patient-provider connections through that, I think are
that's
important.
a great point, and we talk about this all the time in our practice, but something like palliative care, maybe it's a really simple solution. Like maybe we just have to decide that we've given it the wrong name, that it needs to be called something else, because those services are so incredibly valuable to patients. But many of them decline them because they feel like that's the end, or they're, you know, that's hospice, and that they're disconnecting in a way. So, I mean, that's a great point, and maybe we just need to rename some things, keeping the patient centered, not that the name serves us, that it serves them and it describes to them what these services are.
But, you know, how do we advance it? How do we eliminate barriers, put resources? They could be whatever they are, accreditation assistance, or, you know, just policy approaches to helping the healthcare system implement this in a better way.
Yep.
Tracy, can I ask a question? Sorry, I scared
Sorry.
you. Not to put the panel on the spot, but it's in the spirit of blue sky and just how academic centers, community need to work together. Does the panel think there are, and not say it hasn't happened, but more touch points of collaboration across societies and foundations, whether it's around a topic such as AYA or colorectal cancer or lymphoma, whatever it is, or leukemia? And it's challenging because academic centers compete. There's some competition across foundations and societies. But are there ways to let the guard down in certain areas looking forward?
Absolutely. I think not only are there opportunities, I think it's essential to really activate those opportunities. One of the things that I think is so important when battling any kind of outcome like cancer is that it's really important to play to everyone's strengths. And when we talk about collaboration across societies, there is an incredible depth of knowledge within certain societies or foundations that specialize in a certain area. And then there's also a depth of knowledge and expertise in other societies. So the American Cancer Society is a large volunteer-driven organization. We have over 2 million volunteers. We have a number of different partnerships with different hospitals and health centers. But we also know that when we're trying to help a patient that is experiencing a certain type of cancer, that there may be a foundation or society that is really well equipped to help that patient or to help us advance that outcome. And by really engaging in meaningful and sustained collaboration, we're able to make much greater progress than if either one of us acted alone. So I think that the model of collaboration that we're talking about is not just about breaking down silos within institutions, but also within organizations that traditionally do compete. And here it's collaboration has to eclipse competition.
So how do we do it? How do we do it?
Yep.
I know
Tax
it's not
credits.
easy, but how do we do it?
So I think one of the things that immediately comes to mind is it's really important for there to be communication between the different societies, and for us to really have a clear and actionable understanding of what are the resources that are available, what are the priorities that are, that are at top of mind for the different societies, and to say, all right, well, where can we work together to really identify those opportunities for collaboration, and then to develop that actionable roadmap for this is what we're going to do to work together around this issue. We have, just on this panel here, we have, incredible resources being dedicated towards research. We have some of the top researchers in the world being funded. We have thousands of patients that are benefiting from the work of everyone on, not just up here, but across this room. So, but it's really kind of figuring out the what. What are those specific opportunities, and for people to come together and have those conversations and say, well, let's figure out how to work together.
And I think that's critical from all of us. And I think, not that it's going to be answered right here in this panel, but thinking more about that. Meg, do you have any input?
Yeah, I think you're right. I think identifying those areas of both greatest unmet need and opportunities for collaboration is important. And one of the things that has come to my mind as we've been speaking this morning and listening to the Vice President is the issue of clinical trials. So the White House obviously made several announcements this morning, which the Vice President alluded to, ranging from the establishment of the Oncology Center of Excellence at FDA, this virtual formulary at the National Cancer Institute. I even read a proposal this morning to nominate the FDA commissioner to be a cabinet-level post so that they could report directly to the president and really have his or her ear in the future moving forward, and that's one way to really prioritize the issue of clinical trials and some of the regulatory challenges that we've faced. And I think across the spectrum, across disease states, this continues to be a challenge, but all of these issues, all of these new programs are really predicated on the idea of increasing clinical trial enrollment and patient education around clinical trials. And I really think that could be a core area where if we can come together with collaboration, education can beget access. And I think that can also be a wonderful area, to your point, Dr. Evans, about including not only academia, but community centers where we know the vast majority of cancer patients receive their care.
Well, and that's the kind of next step is, and it's not easy, but how to incentivize that kind of research. In other words, the research, the funding has been fantastic, but to go the step further, is there a way to incentivize not just multi-center collaboration, but also involving the community, oncologists?
So without a doubt, I know that I would have more patients who would participate in clinical trials. I have trials in my office, but I don't have the breadth and depth that the Boston institutions have. And the barrier, and Sharon Snell can speak to this a little bit, is the number of visits that they have to make down the highway. And time is precious to people who have cancer, and making a trip to Boston to get a comp panel and a CBC just because they're on a clinical trial is sometimes what is the no. And if we could break down some of those simple barriers and get more than 4% of people on studies, then I think it would be an easy early win to, double the knowledge base on research studies in the next decade.
You're definitely hitting on, what could it incentivize, and what do we need to remove structural barriers? When we look at workforce issues in the health workforce, there's funding for enhancing primary care providers at federally qualified health centers or whatever it may be that's through HRSA, Health Resources and Services Administration. Maybe we need some funding streams to help, lower access areas become part of the trial networks. And when you look at public policy, that is an area where cancer organizations have come together quite a bit. So nationwide, there's One Voice for Cancer at each of the state houses, not only through New England, but all through the country. That's where people come together around common issues. If it's a, access issue or a, public health, public policy issue, different organizations definitely join together around common goals in public policy. And if we could do that around clinical trial, structural barrier removal and incentivizing, that could be a really strong approach.
I think one other quick thing that comes to mind too is when we talk about putting the patient first, when we should do the same thing when we talk about clinical trials, and how do we break down, as Randy was talking about, the access barriers we have a number of programs that are in place to help patients access treatment. So whether it's transportation programs, leveraging the volunteer base to provide patients with rides to cancer treatment. So how do we make sure that we also think about that in the context of clinical trials, but then also models that we know are effective in other realms of cancer prevention and cancer intervention, and importantly, patient navigation. The healthcare system is so complex, and it's even more complex when patients are trying to navigate clinical trials. So how can we better leverage the patient navigation model to help patients successfully go through clinical trials, and importantly, to help patients who may have additional barriers tackle those barriers so that they can enroll and successfully complete a clinical trial.
Just quickly, any burning questions in the audience? We don't want to. Tarek?
So I'm Tarek Mughal. I'm with Foundation Medicine. I'm also on faculty at Tufts. With regard to clinical trial, we have to acknowledge that with the integration of genomics into clinical practice, the modus operandi of clinical trial, they've also altered drastically, okay? And they will continue to evolve, okay? So this actually increases the onus on having more and more trials in the kind of hub and spoke model, where in the academic center, you have people who are on the ground floor and able to integrate the challenges which we are uncovering every day with the introduction of genomics, okay? For example, the surrogate markers which we have been using for the last 30 years or more for clinical trials are increasingly being redundant, okay? When you look at immuno-oncology, for example, we're struggling to establish surrogate markers. So these are very important things. All of us, as we will hear more and more as the afternoon progresses, we have an enormous amount of enthusiasm, but we also have a responsibility to the society to bring all the enthusiasm into reality, okay? So this is something which has to be thought through very, very carefully. This is why in the introduction which Andy gave, it was so stimulating to hear that one of the key things we need to do is to break down these artificial barriers which we have, create more collaborative things. Thank you.
So
any other? Just a quick one. I don't want to. Burning.
Break, let them talk, and then do your next.
Okay.
Yeah.
So to get this back on time, gosh, we could go for another hour.
I have
Right.
one comment I would make.
Okay, Dana, you
which
got the
is,
last comment.
Some would say the last 5 years or so was about big data everywhere and the ability to pull it all together. And it feels like, partially based upon the investment opportunity flow that we see, but also the press and everything else, that where we are is now, what do you do with the big data?
Right.
And the electronic medical record is a billing business. I'm sure you all love working with the electronic medical record, those of you. We get to see more doctors' ears than anything else, right, as patients. But I think where we are in the outcome analysis and tracking cancer is very exciting, and there are many companies out there now that are getting formed to do that. So I think what might be able to be done is that the government may be able to help incent the electronic record to now add value not only in patient accrual, but really understanding what works with which patients. And I think clearly in Boston, I think everyone knows that the Tufts system doesn't integrate with the partner system. And having a much more effective communication systems around the country and incentives for those for-profit systems to improve their communication, I think would dramatically.
And to link with the community.
Yep.
Absolutely.
Correct.
Well, we'll let that be the last note, and thank you. We see that as the beginning of the conversation, so we're going to take a quick 10-minute break. It's a last call for food, I was told, so grab that if you want to get a last dessert. But let's take 10 quick minutes. Thank you.